genesis for these office hours in the beginning? COVID-19. 3.5 years later, and we're still trying to figure out the right balance, particularly in our food production facilities. Is it still out there? If and when should employees mask? Should I have employees test? What do I do if someone in the facility tests positive now? We're clearly not doing what we did at the beginning of the pandemic, and we clearly can't do what we were doing before the pandemic. So today, we got two great guests that are going to give us a better perspective on where we are now with COVID-19, how we should be responding, and how we should be planning for COVID-19 in the industry going forward. So today, joining us, I'd like to welcome Bryon Backenson. He is the director of the Bureau of Communicable Disease Control in the Division of Epidemiology at New York State Department of Health. He oversees the department's investigation of communicable disease outbreaks in New York and collaborates with other states and the CDC on multi-state outbreaks. He's also an assistant professor with the University at Albany School of Public Health, where he directs and teaches the annual infectious disease epidemiology course and provides lectures in several other graduate and undergraduate courses. Thanks for joining us, Bryon. And then we've also got Jack O'Brien, who is the supervisor in the New York State Department of Labor's Division of Safety and Health. He manages a team of 12 inspectors who enforce the laws passed by the HERO Act, which has got a lot of discussion around it, which passed during the COVID-19 pandemic. Before joining the Department of Labor, Jack was a small business owner. He's a graduate of Hamilton College and a proud member of the Mendon, New York Volunteer Fire Department. So glad to have you here too, Jack. Just as before I hand everything over for some of the presentations, just to remind everybody, some of you submitted questions as you registered for the course, but if you do have questions, start thinking about them. And then when we get to the Q&A section, there is a chat box. If you look at the bottom of your screen and click that little chat icon, and you can either type the question and send it to myself if you want to remain anonymous, or you can send it out to the group and we'll get to those questions that we see in the chat box. So with that, I'd say let's take it away, and I'm going to pass it over to Bryon to kind of give us his view on what's going on right now. Thank you, Bryon.
Okay, great. Thanks. So first of all, I apologize for not doing the video thing. For whatever reason, my laptop doesn't seem to be working very well, and hopefully it's not too loud in here. I'm wasn't expecting to be on the road today. But I am. I'm on the road because we were doing some conference across the state, stopping in a couple of different places and talking about some other different things. And we had two speakers get COVID. So one of my issues now is I'm on the road sort of pinch hitting for some of those speakers who couldn't necessarily be here. So hopefully I've got myself into a relatively quiet spot in this banquet hall to be able to do this. So we'll go from here. The main thing I think I wanted to do is just give you all kind of a quick update on where we stand with regards to COVID. Try and talk a little bit about sort of some common sense stuff that we have, and show you, in a perfect world, I'd be sitting here in a place where I'd have a live internet feed and kind of show you where you can find some of this information as well. But I've tried to put some of the links at the bottom of the sheet so that you can get a sense of where you can find some of the information if you wanted to look for some of this stuff yourself as well. My contact information is there at the bottom. It's also going to be on the last slide, but feel free to reach out if you want to wind up talking to me about any of this type of thing. All right, let's go to the next slide. All right, so the first thing I think that this is kind of a quick overview slide of everything that we're going to hopefully talk about here. There's a lot of different variants that we're seeing in New York State. We're not getting as many samples as we used to have. The information that we're, obviously you and I, if we wind up testing ourselves for COVID, we most of the time do it on our kitchen tables now, or in our bathroom somewhere. And therefore, it means that we don't have as much information about what's going on. We do have information that we get from hospitals, which is quite good. And what we're doing there is getting some of those samples sent off to our lab, testing and trying to figure out what kind of COVID, what strains, what subvariants and so forth that we're actually seeing across the state. So we'll talk a little bit about that. That all being said, we do look at case and hospitalization data, mainly hospitalization data now. And from what we're seeing so far, it doesn't look like the new variants that we're seeing are more severe than previous ones. It makes it, again, the lesser data we had makes us a little less confident in some of this because we don't necessarily have as good information as we had in the past. But, you know, hospitalizations are still probably our best measure for this because they indicate, you know, the sickest people in terms of going to the hospital. So we'd hope that we would get some good information on severity, sort of no matter what. There's some things about these variants. The second sub bullet here about transmission advantage can lead to increased infections. You know, even if the new variants that are out there aren't as severe, if they're have changes in them that make it easier for them to get passed from person to person, that's going to mean that more people are infected. And with anything like this, the more people you have infected, there's always going to be a group of people that are going to need medical care. So the more infections we have, the more people that we're going to see that are going to need, you know, medical care to either go to their doctor, or go to the hospital. So even if for the majority of the population, it's not a change that would make things more severe, but if we have tons and tons of cases, we are going to wind up seeing more people need to go to the doctor, need to go to the hospital. So that's, you know, just sort of simple math, but it's worth sort of thinking about. And one of the things that we as a health department consider is trying to make sure that our hospitals don't get overrun and so forth when it comes to COVID. That hasn't happened lately. Hopefully it won't happen in the future, but it's something to keep in the back of our head if we wind up getting a new strain that all of a sudden can infect practically everybody. We are seeing cases and hospitalizations increasing, and we've been seeing that since June or July or so. You know, the numbers in magnitude are not what they were in the past, but we are seeing both, again, cases and hospitalizations increasing, and that slope is continuing to go up. So it's not surprising, and it's not surprising given the time of year we are, where we start to, you know, spend more time indoors. You know, kids go back to school. We're, you know, not vacationing as much, and we're in more close proximity to one another. And it doesn't surprise that, you know, this is why respiratory season, cold season, flu season, COVID season, why we see more cases at this particular time of year. There has been a new vaccine, which you probably have heard about in the news over the past few days. It's been approved. It should be available now within days. We're probably going to wind up seeing, last I'd heard, I think it might be in, you know, pharmacies as soon as, say, Saturday, depending on how they've been able to put in orders and so forth as well. And then the last thing here is a shift towards like an all respiratory approach. This is something that I think CDC is trying to do, and we'll talk a little bit about that in a sec. So let's show you a little bit of data. The next slide. COVID hospitalizations are up basically 15.7% week over week. That's in the United States. You know, an average of, you know, 2,000 new hospitalizations. Deaths are up as well, 17.6% week over week. You know, in absolute terms, the number of deaths may not necessarily be something that you may wind up seeing great big numbers of, but again, the number of people that are dying from COVID is still pretty high up there in the grand scheme of things. It is now one of the you know, top 5 causes of death in both the United States and in New York. So even while we may think, you know, not as much is going on, we are still seeing a lot of people dying still from COVID. In New York, our hospitalizations are up as well, and our hospitalization rate has gone up as well. And those are, you know, commensurate with what it is we see across the entire country. Wastewater surveillance is something that, again, you may have heard about. We're seeing increases in all 4 U.S. regions across the United States. And in New York, where we do some wastewater information as well, which we'll talk about in a sec. We are seeing increases in the amount of COVID that we're seeing in wastewater catchment areas. So we'll talk about that in a sec. And I see Beth put the link in, and there's another link where you can wind up getting to some of the data specific for New York. Next slide. Next slide, please. Uh-oh. I still see people's heads turning, so I'm not frozen. Can we jump to the next one, Beth?
Do you see it? It shows up on my screen. Did I?
Oops. Well, okay. Oh, there we go. Okay. So now I see it. This is a slide with a big ball of variance on the left and some graphs on the right. This is basically to show you that COVID is, you know, when we talk about variants of COVID, there's tons and tons and tons of them. All those individual dots that you wind up seeing on the left-hand side of the screen are COVID variants. They're different genetic makeups of COVID. And these are just the ones that have been seen in the past 21 days. Not every single variant that we wind up seeing or it gets genetically sequenced is actually going to turn into something that's big and important. And just because something is new and something is a variant doesn't necessarily mean that it's bad for people as well. A lot of these variants have no difference whatsoever in terms of what it is that we're seeing. And some of these variants may actually be worse for the virus. Typically, those are ones, unfortunately, that don't necessarily make it. But if you wind up looking on the right-hand side of this, that graph at the top, this is, again, the last sort of 3 weeks worth of data. And the lines at the bottom, the lines there are basically showing the number of different variants that we're seeing sort of comprising infections. And you can see as we head towards the right, we're getting lower and lower and lower the number of variants that are out there making people sick. So we've gone from kind of a lot in the past 2 weeks, and we're kind of simmering down to, it looks like 2 or 3 that are going to be the kind of the causes of infection. We expect to see that sort of moving forward. It's something that's called convergent evolution. And every once in a while, we wind up seeing something that breaks, and all of a sudden we get a whole bunch of new variants. But usually over time, a couple of those tend to be the winners. And when we wind up seeing those, they eventually wind up causing most of our illness. This is information for the United States. If you go out to the website, the link's there at the bottom, you can actually drill down to New York for this. But this is more so, again, just to kind of let you know that, we talk about these variants and, beta and gamma and Omicron and so forth. All of these ones that you see here on the right-hand side, by the way, are Omicron. They're just different sort of subvariants of Omicron. When you wind up hearing about new things, everything now is under the Omicron umbrella, which gets back to the vaccine that we're talking, the new vaccine, which is now geared towards Omicron, which means even if you get one of these ones or are exposed to one of these ones that you see in one of these balls on the right, and the left, sorry, the new vaccine ought to protect against it. So just a little bit about how the variant sort of terminology and how it goes. Next slide. There we go. So this is cases that we're seeing. If you look at the scale at the bottom, this goes back to October of 2022. And if you look out to the right-hand side of this, you can see obviously that slope has gone up starting in July, and it's gone up in August and now September, and it still seems like it's continuing to go up. There's a couple of them there. Looks like Long Island is that green one at the top. It looks like it might be starting to hook down. But again, in the grand scheme of things are continuing to wind up going up. But if you look back, this is, again, different from what we saw last winter when Omicron really first sort of popped out. So we're seeing an increase, but, comparatively, that increase is much less than it was before. Next slide. This is cases. Next slide here is hospital admission. So again, like I mentioned at the beginning, hospital admission data is much better than case data for what it is that we have. It's a more robust set of data. And you could, again, same deal over on the right-hand side here. You can wind up seeing since July, when things sort of bottomed out, you can see that hospital admissions for COVID have continued to go up over the past couple of months. And we're not necessarily seeing a slow to that quite yet. Hopefully this will start to flatten out a little bit, but again, we're starting to see, we have seen for 2 or 3 months now, this hospital admissions start to perk up. Next slide. So what about this one? This is a kind of looking at a ratio of hospital admissions to cases. So it's sort of comparing the two. So for every case that we see, are we seeing people actually get hospitalized? This might give a little bit of an indication of whether or not there's some severity. And again, if you look at this graph looks relatively flat. And if you start to look starting in April of 2023, where you see a lot of wiggle in those particular lines, and then it actually looks like it actually might be starting to drift off and actually go down a little bit starting in August and September. And these are relatively good indications that even for the cases that we are seeing, and while hospitalizations are up and while cases are up, the proportion of cases that are actually getting hospitalized might actually be a little less, and it indicates that the COVID we're seeing might be a little less severe. Next slide. I talked about wastewater data. I don't know, hopefully maybe there's the link at the bottom of this one as well. But this is kind of a slide for wastewater, and this is on our website. And each of those particular dots that you wind up seeing on that map are wastewater sample sites. They are sewage treatment facilities. And what it is we go in and we wind up collecting right before the water winds up getting into the sewage treatment facility. We'll collect some and then we'll test it for COVID. And the graph that you wind up seeing, or the kind of the scale that you see on the right-hand side, the blue to the maroon, gives you an idea over a couple of weeks, basically, if we're seeing changes over time. All of us, if we have COVID, we excrete it in our stool, and we can capture it in that wastewater once we flush it down the toilet. And if the darker areas here, you can the darker blue areas, like you can see over in the western half of the state, Erie and Niagara, we see that the amount of COVID that we're seeing in stool has actually gone down over the past couple of weeks. But if you look in those oranges, maybe in the Syracuse area, maybe in the New York City area, you can wind up seeing that the amount of COVID that we're seeing in wastewater there has actually gone up over the past couple of weeks. So this is kind of a good indicator of what it is that we're seeing. There's a couple of other things you can, if you got out here, which you can with the link, and sort of mess around. You can pick by county. You can pick by kind of a detection level and just see whether or not the amount of COVID in wastewater sample is kind of considered to be sort of high, medium, or low. But I always tend to like to look at these trends and see if things are getting worse or getting better. So this is kind of the view that I tend to like. Next slide. This is just looking at detections in wastewater. And again, if this goes back to January of 2022 on the left-hand side, up to the beginning of September here on the right. And just like everything else, things bottomed out in, April and May, and things have perked up a little bit since July and August in terms of COVID that we're seeing in wastewater. This slide also you can wind up seeing out on our website as well. Next slide. So the COVID vaccine that you've heard about in the news, let's see if we can go through it, just a kind of a quick and dirty sort of summary of this. It's one dose. So instead of the 2 doses that people have had before, it's 1. It's recommended now by CDC for everyone from 6 months and up, regardless of whether or not you had previous vaccinations. You can sort of think about it a little bit like an annual flu shot, if you will. It basically will protect against infection in the short term and then protect against severe illness and hospitalization in the longer term. It boosts your immunity so that, if you get exposed to COVID within a few months, hopefully you won't get COVID at all. But as time goes on, and perhaps as some of the protection, some of the short-term protection sort of wanes, and you're exposed to COVID, it'll trigger some different kinds of antibodies inside you, and that should help to protect against severe illness and hospitalization. So it's a good idea in a couple of different ways. One in terms of the short term, and then one in terms of protecting against severity in the long term. Like I mentioned earlier, it's based on these XBB variants of Omicron, which means that it should cover kind of what we're currently seeing circulated, and hopefully the new variants, at least given the way that the virus has been evolving. COVID has evolved so much, or SARS-CoV-2, the virus that causes COVID, has evolved so much that original 2-dose vaccine is no longer approved for use. If you got vaccinated against it right now, it wouldn't work. It is one of those things that, the virus has evolved so much that original vaccine just doesn't have any efficacy anymore. So if all you got was 2 doses when, you could go to assorted places, drive-in places, and get vaccinated and whatnot, you shouldn't consider yourself vaccinated anymore. And again, this is one of those reasons why we're trying to push this newer vaccine. This one is just Pfizer and Moderna. It's not Johnson & Johnson. So originally there were the 3, Pfizer, Moderna, Johnson & Johnson. Now this is just Pfizer and Moderna. Novavax is coming. Pfizer and Moderna are what we call mRNA vaccines, and Novavax is a vaccine that is kind of created in sort of the traditional way. It takes a lot longer, but it is, that's coming as well, probably over the next few months. But the 3 companies out there that are going to have this updated COVID vaccine for the United States are going to be Pfizer and Moderna and Novavax. This is likely going to be the pattern that we're going to see year after year after year, right? This is going to be similar, likely to flu vaccines, where we're going to wind up having, apologize for the noise if you can hear that, it's where we're going to basically try and see if we can get people a new vaccine in the fall. And, we've had a number of new vaccines now, and this is kind of the first time in history we now are going to have vaccines against all 3 winter respiratory viruses. COVID, flu, and RSV. RSV, or respiratory syncytial virus, is another disease that typically is most impactful for really, really young kids or senior citizens. And there are now vaccines that are available for that as well. So we're in a real kind of like renaissance for vaccines. And in some ways it could come at a worse time because a lot of people are now anti-vaccine, or, not a great big fans of the way that the COVID vaccine sort of rolled out. And, I think a lot of our communication about it wasn't all that great, but, we're trying to do what we can in order to make this happen, because I think all these vaccines are really good opportunities to try and prevent people from getting ill. Next slide. And this is one of the reasons why I think it's important to do that. I mean, this is these are people hospitalized by age for COVID just in 2023. So the first half of 2023. And if you look at, pick your favorite column here, whatever age you are, and if you look and see who was hospitalized, for that 18 to 49, 35% of the people that were hospitalized never got vaccinated at all against COVID. 53% of the people who got vaccinated were vaccinated, but they didn't have the bivalent booster. They were vaccinated kind of from the first original sort of dosages of the COVID vaccine, like I said earlier, that don't really work anymore. Only 8% of the people who had get that updated bivalent booster, which came out roughly a year ago, became hospitalized. And some of those people may have had other comorbid conditions and so forth. But again, it's those yellow bars at the top, the 8, the 13, the 19, the 19, those are the people that got the updated bivalent booster that was more geared towards what was actually circulating at the time. And you can see those people were the ones that were the least likely to wind up getting hospitalized. So again, this is sort of some data to try and push to try and get vaccinated. Next slide. And then last but not least, this is like this all respiratory approach that CDC is going to try and do. I think you're going to see a lot less, COVID only talk, and a lot more fall is respiratory season talk, and trying to, get information out about respiratory disease as a whole. So CDC is pushing a lot of things like this slide you actually see in front of you, which has the different colors, the green, the red, blue for COVID, flu, and RSV, and then sort of a black that sort of lumps them all together just to kind of get a look at the respiratory burden that we're seeing. So obviously you could see, last fall into winter, there was a lot of respiratory illness, and then it sort of, peaked shortly before Christmas and then sort of slid down after that. We're starting to see some pickups in flu cases, and obviously in COVID cases, like we've talked about. We haven't seen a pickup in RSV yet, which I'm happy about, but undoubtedly, we're going to get into flu season here over the next couple of weeks, and we expect these numbers to go up. But CDC and probably us at State Health Department is probably start talking about all respiratory diseases in one lump sum, as opposed to talking a lot about, just COVID. I think people are burnt out on COVID. Obviously, you guys, I'm sure are. I am, and it's one of those things where we're going to probably start talking about just how you can protect yourselves from getting all respiratory diseases. So one more slide is my contact information. Again, if anyone wants to talk to me, obviously we'll be here to answer questions too. But I'll pass it back to you, Sam, I guess.
I'm gonna unmute myself here. Thanks, Bryon. That was great overview of what's going on, and answered a number of the questions that were kind of submitted. So that was a great greatest hits. And we're gonna hear then a little bit more on the regulation side when we pass it over to Jack.
Hi, everybody. Can you hear me?
Great.
All right. So I'm going to share my screen here. What's that? Can you guys see that PowerPoint, or what are you seeing right now?
Nothing right now.
Oops. All right. How's that?
Yeah. Now we can see if you hit presentation mode or start the slideshow, it should be good then. Yeah.
So again, my name is Jack
Oh,
O'Brien.
Yeah,
Hello.
you still gotta
everyone.
hit start slideshow. Sorry,
Where? I'm
because
sorry.
right now we see all your.
No, I do not see that. I'm sorry. I'm
You see that on the menu bar slideshow over there? On your PowerPoint menu bar, home, insert, design,
we're on the
transition.
wrong. There we go.
Yeah. Slideshow and then start it from the beginning. Yeah.
All right.
Good, perfect.
Sorry about that. Technological
Yeah.
difficulties. Thank you, Brian. That was really informative. I'm still learning an awful lot of stuff about COVID. It's fascinating because there's always new information. And like Brian said, it's been around now for 3.5 years, and we're still seeing new stuff. But now that was interesting. But now we're going to talk about the law, which I'm sure everyone is even more interested in. Like I said, I'm a supervisor for a new bureau within the Department of Safety and Health at New York State, and we were tagged with the unfortunate name of HERO. It stands for the Health and Essential Rights Act, which is really HERA, but they called it HERO. So I'll try to live up to that. And I need to move that. Anyways, so the HERO Act there's a couple different parts of it. I'm going to go over this very briefly. At the end, there'll be contact information for myself, also for our mailbox where you can call or you can email and ask any kind of general questions you have, and a link to our website where you can find any of the information I'm talking about today in much more detail. All right. The first part of it is called ADEP, which is the Airborne Infectious Disease Prevention Plan. And this was enacted in May 2021. And basically, it just says that employers must adopt a safety and health plan for the pandemic and for their workplace to give, to sort of have a plan in place for when there is an infectious disease affecting all of us. So the law says that all private employers in New York State, and there's a separate law for public employers, but all private employers are required to have an airborne infectious disease exposure prevention plan. The important things to remember is that a copy of the plan must be provided to employees. It must be given to new employees when they're hired. It should be posted in your work site, maybe on the employee bulletin board where information for employers is normally posted. And it also has to be available for both the Department of Labor and the Department of Health if we actually request it. And in our case, we would request it if we received a complaint from an employee. What should it include? And again, there's no group. We can't answer that for everyone because everyone's work site is different, depending on what type of business you're in, whether you're in a confined space, if you have ventilation. There's just so many factors involved. So what we've done is, and an employer can create their own plan as long as it has all the requirements in it. But what we've done on our website is given templates that list like minimum controls that everyone should put in place. But then there are within that on the website different industries that you can actually go on and they'll show you some more advanced engineering controls that you might be able to put in place to keep your workplace safe. But it also it should show who's in charge. It should say on there who employees should go to if they have questions about the plan. And again, the way we take complaints about this, when someone does not have, when an employee says, my employer has never had an ADAP plan. Obviously we're getting less of those now because the designation is off. So the requirement now is that you have a plan, but it does not have to be, you don't have to enact the plan at this time because we're in a designation off status. The designation is to be put back on. It would be the commissioner of the Department of Health that would make that decision. And again, we would go from there. What employees need to know about that is that the plan should be available to them. And if they think their employer doesn't have one and they request it and it is not provided, they can file a complaint with us. What we do from there is we contact the employer, we ask them for a copy of their plan. And, for employers, we're really, our goal is compliance always, and I've worked for different parts of the Department of Labor in enforcement. And that's really always our goal, is to try to get compliance. And, this hasn't happened a lot, but if someone, if we fielded a complaint and we've asked for a plan and someone doesn't provide it, there are penalties in place, and an employer could actually be fined up to $50 a day for non-compliance. Second part of this is called the Workplace Safety Committee. I won't spend a lot of time on this because, to be honest, we haven't fielded many complaints about it. I think a lot of larger employers already have something like a Workplace Safety Committee in place, but this is a way, and this is not COVID specific, although it was included in this law, because it's just a way for employees to feel like they have a safe workplace to voice concerns about safety in their workplace. There's a lot of rules, requirements, and who can have one, who should have one, what the ratio between non-supervisory employees and management is. And all that stuff again can be found on our website. Again, that's not something we've really fielded many complaints about. The one we have fielded many complaints about is called COVID paid sick leave. And this is what we probably, I have a team of 12, and probably what we've in the past spent most of our time with. It's slowed down quite a bit, obviously, because we just are not seeing the number of cases. But this was something that was enacted in 2020, and it is, and there's some confusion because I think some folks may be under the impression that it's no longer in effect, and it actually is in New York State. And there's also, we end up with some confusion sometimes, because even if an employer is out of state, but you're and a lot of people work remotely. But if you're an employee that works in New York State and you're entitled to COVID paid sick leave, according to the rules. It has to do with this, how much an employer is required to provide, has to do with the size of the business. If you're a small business, you don't have to provide, if you're less than 10 employees, you don't have to provide COVID paid sick leave to an employee, but you have to have their job waiting for them when they come back. In other words, someone can't lose their job for going out because they were positive with COVID. The other thing to remember is that this is a separate sort of leave. It can't be taken out of someone's paid time off. It can't be taken out of their sick time, their vacation time. It's got to be done separately from their accruals. There's also stuff on our website, a lot of information available for if someone has used up all their COVID paid sick leave and is still sick, then you would probably use accruals, and then there's family paid leave, and there's instructions on that and how to do that. What we in my department, we take complaints from employees whose employers have not paid them COVID paid sick leave, and we contact them and try to make sure that they get paid or get their sick time or wherever the time was taken from restored. So, as an employee, what you need to know, if you do test positive for COVID, you should provide your employer with a copy of the positive test, along with something called an affirmation of isolation. Another thing I'd like to make clear is I still hear people talking about quarantine. For the purpose of what we're doing, we don't have quarantine anymore. It's just isolation and quarantine. And this is, and it's caused a little bit of confusion because this law was passed earlier when people were still maybe not positive with COVID, but had to quarantine because members of their family were. At this time, though, you only get COVID paid sick leave if you are testing positive for COVID yourself, and you have an order of affirmation of isolation. That can be found on our website. It can also be found at most websites from the county health department. You get 3 instances of COVID paid sick leave. That's it in your lifetime. That's also caused a little bit of confusion. Not 3 per year, not 3 per employer. It's 3 times in your whole life. Another important thing to remember as an employer, is that, and this has to do with almost every employment law that in New York State, is that you can't retaliate against an employee for using one of their rights under the HERO Act. So in other words, if someone goes out with COVID paid sick leave, if someone were to inquire or file a complaint about an employer not having an airborne infectious disease plan, if they were punished in any way for that, Mike, and that could be termination, or they think their hours were adversely changed or something. If they have something that appears as as some sort of punishment for that, they can file a complaint with us, and we take this really serious. And an employer who retaliates against an employee could be fined up to $20,000. And an employee could receive back wages and liquidated damages also. So that's something, we were taking hundreds of cases of this a week, a year ago. Now they've started to uptick again, as Bryon was talking about, as the numbers have sort of gone up a little bit. But it's been pretty manageable right now. So, but again, the thing to remember is that it is still in effect, and if someone has any questions about it, we have a general mailbox that you can ask, the Airborne Infectious Disease mailbox there. I've included my email address also. If you have any questions, I promise you I will answer them, or try to figure out. If I don't know the answer, which is very possible, I will try to get you to someone that does, or try to find the answer. On our website, you'll find all the stuff that I was talking about in much greater detail, and some links to some other stuff that you might find useful. So thank you very much.
Thank you, Jack.